Hello everyone, my name is Arun Pugalenthi. I'm from the Pediatric Respiratory and Sleep Medicine Department at KK Women's and Children's Hospital in Singapore. Thanks to the organizing committee for giving me an opportunity to talk on sleep and breathing in children with Prader-Willi syndrome. It is a huge topic. I'll try to cover as much as I can in the next 20 minutes or so. I have no conflict of interest for this presentation. The outline of my talk is I'll cover a bit on overview of human sleep, abnormalities of sleep in children with Prader-Willi syndrome, and how you assess sleep disorder breathing, investigation and management of sleep disorder breathing, and growth hormone and its effect on sleep, and I'll summarize at the end. So, overview of human sleep. The importance of sleep could be seen from the fact that people spend about a third of their lifetime in sleep. Sleep is a complex neurological state. Its primary function of providing rest and restoring body energy levels. There are two kinds of sleep. Non-rapid eye movement sleep or NREM sleep, which is supposed to do reparation of the body tissue, and REM sleep or the rapid eye movement sleep, which plays an important role in restoration of the brain tissue. Sleep plays a vital role in neuronal myelination and neuronal networking, and especially the REM sleep plays a key role in learning, unlearning, and memory and processing. Sleep deprivation can affect memory and cognitive processing, especially associative memory. So in this slide, on the left side is a total sleep duration across age group from birth through to 16 years of age. On the x-axis is the age and the y-axis is hours of sleep. As you can clearly see, the newborn babies sleep for long hours up to 16, 17 hours. And the sleep duration gradually decreases as the child grows, and at about 16 years of age, they hit adult sleep, which is about 8 to 9 hours of sleep. On the right side, it shows the REM sleep and the non-REM sleep percentages. And you can see it's very clear, very visible that preterm infants, term infants have higher proportion of REM sleep, which is marked in red, and the non-REM sleep is marked in yellow. And as they grow older, the percentage of REM sleep decreases. This will be an important role in regards to the REM sleep in the myelination, neuronal networking, which happens significantly during the early years of life. With regards to breathing, breathing is required for normal oxygenation of the red blood cells to deliver oxygen to the body tissue and brain tissue, and is important in oxygenation and also carbon dioxide clearance. You need to have a good central drive from brain for the breathing, for the skeletal muscle to perform normally. And particularly important is the REM sleep, where there is relative skeletal muscle hypotonia, which is present in all human beings. So respiratory system is vulnerable in sleep, especially more so in the rapid eye movement sleep. In children with PWS, they have a high arousal and blunted ventilatory response to hypercapnia, and poor arousal and cardiorespiratory responses to hypoxia, which plays a very critical role in the development of sleep disorder breathing, which we will talk in the subsequent slides. So what are the abnormalities of sleep in Prader-Willi syndrome? It can range from excessive daytime sleepiness, or some children can have narcolepsy, which is a condition which has irresistible urge to sleep and excessive daytime sleepiness, or they can have sleep disorder breathing, where they can have central sleep apnea, obstructive sleep apnea, or hyperventilation. Excessive daytime sleepiness. It's a common feature of PWS, and this occurs despite they having an increased quantity of nocturnal sleep. So it is thought to be due to hypothalamic dysfunction. The excessive daytime sleepiness can be multifactorial because of disruption of sleep, where they can have difficulties with initiating sleep, nocturnal awakenings, and behavioral issues associated with PWS. Or it can be related to underlying sleep disorder breathing, which causes disrupted sleep, poor quality sleep, causing daytime sleepiness. Or some children, it can be due to narcolepsy. The hypersomnia is thought to be related to the hypothalamic dysfunction, and some children can have the narcolepsy-like phenotype, where they can have sleep onset REM in the daytime, and sometimes they can have cataplexy, which we will talk in the coming slides. Orexin A or hypocretin 1, it's a neurotransmitter, and it is an important neurotransmitter in maintaining wakefulness. In children with the narcolepsy phenotype, in PWS, they have absent or very low levels in the CSF. And some children, they noted to have intermediate levels of orexin, not to very low levels like narcolepsy. So narcolepsy is characterized by excessive daytime sleepiness, sleep paralysis, hallucination, which can happen on falling asleep or waking up from sleep. And they also have fragmented sleep, with or without a cataplexy. So the two types of narcolepsy, type 1 is narcolepsy with cataplexy, type 2 is narcolepsy without cataplexy. What is cataplexy? It's sudden, brief episode of skeletal muscle weakness triggered by strong emotions, which can be anger, laugh, or crying, strong emotions. So they can have a full-blown skeletal muscle weakness where they can fall to floor, or it can be partial, where it can cause eyelid drooping, twitching, slurred speech, facial drooping, lip smacking or twitching of the facial muscles, or sometimes they are just reported the child is clumsy. This is thought to be related to the REM sleep, which is happening during the wakefulness. As you know, REM sleep causes skeletal muscle hypotonia. So narcolepsy, how you assess, diagnose? So we do reported sleep diaries, and we do objective monitoring of sleep and wakefulness. The objective monitoring can be done using a device called ActiveWatch, which is like a Fitbit, which is an expensive Fitbit watch. And you have, this monitors activity levels. And they have a light sensors. This is to monitor any ambient light. So when you're asleep, you shouldn't be moving much and your light should be off. There shouldn't be any ambient light. If the opposite, then it is reflecting wakefulness. If you see any ambient light and more movement during the sleeping hours, then which means the child is actually awake. So this gives an objective monitoring of the sleep-wake cycle along with the sleep diary. Once you know that they have a good sleep hygiene, they are sleeping during the night, then if they still have excessive daytime sleepiness, then we perform an overnight sleep study followed by a multiple sleep latency test. The multiple sleep latency test is where we allow 5 nap during the daytime after a sleep study for a 20-minute duration each. And the child is allowed to sleep during that 20 minutes with a full monitoring of the sleep study. We see whether the child falls asleep, whether they go into REM sleep. If you have a REM sleep during the daytime, after you slept well in the nighttime with a good REM proportion, then it is abnormal. So the diagnostic criteria for narcolepsy is where your mean sleep latency, where after going to bed, how long it takes to fall asleep is less than 8 minutes, and also at least a sleep onset REM of 2 or more. Then you have a diagnosis of narcolepsy. So how you manage excessive daytime sleepiness? You can address the bedtime issues with behavioral modification and sleep hygiene measures. you can extend the nighttime sleep so that the child get longer duration of sleep. And you can do structured daytime activities and daytime nap to counter the daytime sleepiness. Very important in this group of children is to rule out obstructive sleep apnea. If you ruled out all this and if it still persists, after careful selection of patients, we can use stimulant medication, which can be methylphenidate or modafinil, which are medications to keep you awake during the daytime. Next, coming to the sleep disorder breathing in Prader-Willi syndrome. So a normal equilibrium between the respiratory load and central drive. So brain sends signals to the respiratory muscles, which is effective signals, and the respiratory muscles are working well, and the respiratory load is constant, then there is a balance. If there is any changes to the drive where it is less, muscles are weak, the load is high, then it causes a disequilibrium. So in Prader-Willi, they have a delay in maturation of the central ventilatory control centers, and they have high arousal and blunted response to hypercapnia and hypoxia. On top of that, they can develop obstructive sleep apnea and obesity, which can cause increase in the respiratory load. And growth hormone, we will talk at the slides later, which also causes stress on the body, which increases the load, and it causes the disequilibrium. So how you can assess sleep disorder breathing? By history and examination and tests. History, you can assess the duration of sleep, regularity, bedtime problems, and whether they have any fragmented nighttime awakenings, whether they have any symptoms of snoring, coughing, choking in the night, restless sleep. If the parents notice any apneas in the morning when they wake up, whether they have any tiredness or morning headaches. There are questionnaires which is being used to assess assessment of sleepiness, example, Epworth sleepiness scale. On examination, look for obesity, neck circumference can be measured, adenoidal and tonsillar hypertrophy on examination, and Mallampati score, this is to assess the oral cavity to look for any evidence of decrease in the oropharyngeal space, which can contribute to sleep disorder breathing and snoring. And blood pressure to look for any cardiovascular side effects of sleep disorder breathing. Overnight investigation and pulse oximetry, which is monitoring the oxygen and heart rate during the night, which can be performed in hospital or at home. And the sleep study or polysomnography, which is majorly done in hospital in children. So obstructive sleep apnea is a very high prevalence of OSA in Prader-Willi syndrome, where it's supposed to be under 80%, which the meta-analysis show, which is very high compared to prevalence in the general pediatric population, which is about 1 to 4%. And peak incidence of between 3 to 6 years of age, where you expect to be adenoidal and tonsillar hypertrophy coming into place. Risk factors, as we discussed before, they have altered ventilatory control, hypotonia, obesity, and microapnea, which causing narrowing of the upper airway. All contribute to obstructive sleep apnea. So polysomnography. So polysomnography assesses sleep with various channels, which is continuous monitoring in a sleep lab, which is attended by a sleep technologist. So you have various channels monitoring the electroencephalogram or EEG, EOG, which is monitoring the eye movement, which is important for assessing the REM sleep or awake pattern. And you assess the end-tidal CO2 or transcutaneous carbon dioxide, and also measure the flow of air at the nose and at the mouth. And you have chin EMG to look for any increased muscle activity, and there is a microphone to look for any snoring sounds or any abnormal sounds during sleep. And you have two bands, which is one over the chest and another over the abdomen, to look for movements of the chest and abdomen. You have a pulse oximetry monitoring, which is continuous, ECG, and continuous video recording, and leg movement electromyogram. So this is how the output of a sleep study looks like. The screen on the computer, which shows a continuous recording of the EEG on the top, EOG, which is ocular movements, ECG, snore channel, and these two channels are monitoring the flow of air at the nose and mouth. And this is thoracic movement and abdominal movement, everything is in sync, and you may have the normal oxygen saturation. So this is a normal breathing pattern during a sleep study. So they can have obstructive events, which will be looking at, if you look at this channel, which is the chest and the abdomen, where there is a decrease in the movement and also more paradoxical movement, which causes obstructive events where there is no flow of air. This is measured at the nose. Because there is no flow of air and not enough oxygen, the child desaturates, and you can clearly see. And you see recurrent desaturation following obstructive events. So like this, several episodes can happen during the night in a child. So this is the summary slide of a child who has got severe obstructive sleep apnea. On the top is a hypnogram showing different sleep stages, and the red is the REM sleep, and green is wakeful period, and all others are non-REM sleep. You can clearly see during REM sleep there is recurrent clusters of desaturation, and it progressively gets worse as the night passes because you have more REM sleep during the early hours of the morning. And proportionately, with significant desaturation, there is also CO2 rise, where the child is unable to clear the CO2. So you see proportionate increase in CO2 during those periods. So this is a clear severe OSA child. Next, coming to the central sleep apnea. As mentioned before, it predominantly in children less than 2 years of age and peak in the infancy. The etiology is not very clearly known. It is thought to be related to the delay in the maturation of central ventilatory control centers and also abnormal apneic threshold. In older children, also exhibit high arousal and blunted ventilator response to hypercapnia and poor cardiorespiratory responses to hypoxia. And this predisposed to developing sleep hypoventilation in older children. So this is a central event, a screen grab. And again, if you consider this thorax, which is the chest and abdomen, you see there is a movement and then there is no movement in the chest or abdomen, which means there is no breathing effort at all. And this is the flow of air where there is no flow of air. So there is no breathing and no flow of air. And you see this oxygen saturation goes from 94 through to very low levels. And you can see recurrent episodes of central apnea. So this is how a central apnea looks like, and some children can have very high numbers depending on the underlying abnormality. So when we come to the growth hormone therapy, what are the positive, how does it work? It stimulates basically growth, it increases the basal metabolic rate, and your energy requirement is increased, oxygen consumption is increased. So it is basically put more stress and pressure on the body. So if you already have a breathing problem, or if your breathing is at risk, then growth hormone can make it worse. So what are the positive effects on breathing? It increases resting ventilation and improves central inspiratory drive, and also increased response to hypercarbia, and also improves central sleep apnea. So important side effects of the growth hormone causes the accelerated growth of the lymphoid tissue, which is adenoids and tonsils. The development of obstructive sleep apnea following a growth hormone therapy can happen anytime from 6 weeks up to 2 years after starting growth hormone. So we really need to closely monitor them. And development of OSA is a very important concern, because reports of sudden death reported in children with Prader-Willi undergoing growth hormone therapy. So it's important to assess for any underlying sleep disorder breathing is to perform a sleep study prior to starting growth hormone. And if there is any evidence of sleep disorder breathing, that needs to be treated prior to starting growth hormone. And it is important that it should not be initiated during any acute respiratory illness where they are more prone for worsening of sleep disorder breathing and also reported sudden death. So once they are on growth hormone, recommendations from American Academy of Pediatrics is to do a sleep study 6 to 10 weeks after starting growth hormone to see whether there is any worsening of sleep disorder breathing. And there are other recommendations of within 3 to 6 months after starting therapy, or once a year during treatment. If there is any worsening of sleep disorder breathing, needs to be treated before continuing growth hormone. So how you treat? Obstructive sleep apnea, the first line of treatment is adenotonsillectomy if there is evidence of adenotonsillar hypertrophy. The children who already had adenotonsillectomy, they have still residual obstructive sleep apnea, then continuous positive airway pressure or CPAP to be used for sleep. And weight loss will also help in the treatment. Central sleep apnea, if it is in the infantile or less than 2 years age group, supplemental oxygen improves central sleep apnea. And you can perform an overnight oxygen titration using a sleep study or a pulse oximetry. And if it is a sleep-related hyperventilation in children who are obese, bilevel non-invasive ventilation will be recommended. So non-invasive ventilation, two modalities, continuous positive airway pressure and bilevel positive airway pressure, which is delivered via interface or masks. Everybody knows this is different and the size, shape is different. So not one mask will fit every nose. So we have different masks for different age group. So on the left top, you see a neonate where there's a nasal prong delivering an IV, and this is a nasal mask in an infant. Slightly older children where it's a nasal mask, and this is an oronasal mask to cover both the nose and the mouth. And this is a child having a nasal pillows, and this is a full face mask which covers the whole face. So it has to be a very careful and customized choice when it comes to the interface. So come to the last slide. In summary, sleep problems are common in the patients with Prader-Willi syndrome. They are at risk of both central and obstructive sleep disorder breathing. Daytime sleepiness is very common in Prader-Willi syndrome. It can have negative impact on cognitive, developmental, and cause behavioral problems. We need to be actively screening for sleep disorder breathing by history and clinical examination and performing pulse oximetry or sleep study. How you manage behavioral modification, sleep hygiene, make sure they sleep at the right time, and maintain sleep hygiene in every day. Excessive daytime sleepiness can be treated in selected population with stimulant medication using methylphenidate and modafinil, and supplemental oxygen in children, infants, and children less than 2 years if it is predominantly central sleep apnea. ENT surgery, mainly adenotonsillectomy, to treat obstructive sleep apnea. In children with residual OSA or obesity hyperventilation, can be treated with CPAP or bilevel non-invasive ventilation during the night. Weight management. And during growth hormone treatment, particular emphasis or careful monitoring and pre and post growth hormone sleep studies to be done, and treatment of underlying sleep disorder breathing to decrease the side effects. Thank you very much for your attention. If you got any questions, I'm happy to take them. Thank you.